invitation to the course. And I'll be going through AB Interno revision. So what is a bleb at risk of failure? If we recognize that, we need to know what to look for. Right, so there are some indicators that point to a risk: excessive conjunctival injection like this, or if there's corkscrewing of vessels. If there's increasing IOP, you should be asking why the pressure is increasing. And typically you could see a high bleb phase, which is insisting of the bleb at about 6 weeks of time, and what they need is aqueous suppressant actually. You could have a flat bleb with inadequate filtration. You need to consider revising, but before anything, always do a gonioscopy and look at your sclerostomy, because no matter what you do, if your sclerostomy is going to be blocked, then doing something in the subtenons or subscleral space is not going to work. So a failed trabeculectomy bleb with high intraocular pressure does have several options. So if you have a scarred bleb like that, you could needle it. You could do a bleb revision, which could be ab externo or interno. Of course, you can do an additional trabeculectomy or a glaucoma drainage device, or maybe a cyclodestructive procedure if there's no useful vision. So how do we decide? A couple of years ago, we actually did a thesis on the clinical utility of the UBM to assess the likelihood of needle success, because what troubled us was not knowing which patient would do all right and which patient wouldn't with the needling. So what we did was we used the UBM at that time to look at the passage of fluid beneath the scleral flap, and the route of aqueous, if we could see it, we call them SRP, or scleral route patent, or a scleral route occluded. And our hypothesis was that the SRO Bleb was likely to fail with needling, which was intuitive because the flap itself has stuck down, and if the SRP or Bleb was likely to succeed. So sure enough, when we said that, so this is what the SRP bleb looked like, and this is what it looks like 6 months after needling, because all you need to do is do a little bit of subtenons fibrosis release, put in 5-FU, and that's it. Whereas if you have an SRO bleb, which the UBM told us, then no matter what you did to the subtenons fibrosis, that is not going to open up, and 6 months later it remained the same. So we did publish that in I a couple of years ago, and we've been using the UBM and now the ASOC to really do something. So now when we realize that an external bleb revision would be required to lyse fibrosis under the scleral flap, it is also true that it's an invasive surgery. It's almost akin to doing a trab all over again, and it does require conjunctival dissection and reopening of the flap. So the whole world is going towards minimally invasive. So this is a sort of minimally invasive revision. It's called ab interno. It's more controlled, and what has helped is the availability of a novel Grover-Feldman biplanar sclerostomy spatula. It's called the GFS spatula. This is what it looks like. The main thing is that it's a long spatula so that you can reach right up to the subconjunctival space through the sclerostomy. It's blunt, and it's about 0.5 millimeters in width, and it's flat, and it also has a bit of a curvature to account for the scleral contour. So these are the principles of the technique. You require an open ostium on gonioscopy. That's the prerequisite. And then you need an inferior corneal paracentesis. You inject viscoelastic to protect the cornea. You insert the GFS spatula under visualization of an indirect gonioscope, and then with side-to-side movement, you can lyse the fibrosis. So showing a case, this 56-year-old man with primary open-angle glaucoma with failed trab, 24 millimeters of mercury on 4 drugs, and a scarred bleb, and a patent sclerostomy. So this is a sort of ideal guy to attempt to open up the bleb from within rather than go externally. So another thing that needs to be given is a subconjunctival mitomycin C, 0.1 milligram per ml. What Grover and Feldman have said in their protocol, it's about a week prior to surgery, but we managed to inject it about 2 or 3 days prior when they come in the preoperative period. So you can see the first thing we've done is inject pilocarpine and constrict the pupil. and then some cohesive viscoelastic on top to put in the lens, and then visualize the sclerostomy intraoperatively as well. So now the spatula is going in, and once the pupil is traversed and you're in the angle, you put in your gonioscope to visualize the entry point. And there is a little bit of corneal folds which do come in, but once the entry point is done, then you gently just do a side-to-side dissection, and this is until you reach the subtenon space. And how you know that is because the spatula is blue, and you'll actually see the blue tip of the spatula, which tells you that you've traversed it. So I'll just show it in a still. Yeah, so here it is. If there is a pointer, if you can see here, this is the mouth, the tip of the spatula which has really come out, and once it is out into the subtenon space, it is easy to keep going side by side and remove all the subtenon. So in one go, you've removed subscleral as well as subtenon's fibrosis and opens up the bleb. So this is the post-op picture of the same person on the next post-op day. You can see that it's become diffused, there's fluid in the bleb, and there's nothing much that you've done. On day 7, he was 7 millimeters. This is on day 30, and this is at 6 months, and the bleb remains much the same. So we're very happy with doing this before going. It's a one step short of doing an external bleb revision or a retrab or a tube, which is always there. But this is one step before that. If all that can be avoided, it's good. So we looked at our data for this presentation. We looked at people who we had done, and we looked at least 6 months data, and by looking at it, we actually saw that we had patients who had completed 1 year as well. So of course we excluded thin cystic blebs, a closed sclerostomy site, or a hazy cornea with poor view of the sclerostomy site. So there were 25 eyes, of which 6 months follow-up was in 25 and 1 year follow-up in 15. PACG was 12, POAG was 6, JOAG 5, 1 NVG and 1 secondary open angle glaucoma. And the mean age of bleb from trabeculectomy was about 5 years. So there were late failures, and the results were actually quite encouraging. So you can see the IOP has changed, as well as the anti-glaucoma medication requirement has changed significantly. And interestingly, of those who completed 6 months follow-up, only 1 failed, who required another procedure. But those who had completed 1 year, the 15 of them, not one of them failed, and most of them, so in fact 40% had a complete success without medication, and 60% required up to 2 anti-glaucoma medications. So far so good. And our first step now for a failed bleb is always an ab interno before opening up the conjunctiva and going in. We did have a few complications. 5 patients had hyphema, that's about 23%, which resolved. 1 had to be drained, and there was shallow AC, and one had an iridodialysis, and 1 had a buttonhole. So thank you, and I hope some of you can incorporate this as well. Thank you.
Thank you, Dr. SUSHMITA. I think it's very important to choose because there are a number of procedures available for these eyes, but which will work for you best or in a given situation. That's very important to choose, and that's what I think one of the procedures Dr. SUSHMITA has